All right, welcome everyone to the Curing Controversy session this afternoon. My job's to whip you into a HAB fan-like frenzy, but hopefully with not quite the same potential for violence. So the program has been building to this point so far. Our theme, turning the tide on HIV, that hints at prospects for a cure. Yesterday, Richard Parker posed the question of whether a cure in the short term is something that he terms a necessary falsehood, like Montreal fans telling themselves the Habs are going to win the cup this year, which nonetheless allows them to move forward with renewed energy and hope and enthusiasm. Or is it really an imminent reality, just a matter of time, like the Leafs going a century without winning the cup? So we have three speakers lined up who we hope will get at the core of this question. So this morning, David Margolis painted the biomedical landscape for eradication, and our first speaker will address those issues. Yesterday, Colin Kovacs stressed the critical importance of limiting the tissue HIV burden. So our second speaker is going to present results from a Canadian study where they're looking at doing this in a very specialized setting. Marina Klein yesterday, speaking about HIV, HCV co-infection, she emphasized how cost is going to be a huge barrier to eradication of HCV. And relatively speaking, eradication of HCV compared to HIV is going to be simple. So the cost of HIV cure may overshadow the costs of HCV and create even more problems. And our third speaker is going to speak to the economic issues associated with eradication of HIV and AIDS. So we'll have three speakers, and we'll have the panelists make comments at the end of each speaker's presentation, and then we'll invite the audience to raise questions or make contributions at the end of that time after the three speakers have finished. So with that, I'll turn it over to Matthias to introduce our first speaker.
All right. Thanks, Mike. I'm quite impressed. The hockey comments, they were written before the game. So it is a great pleasure for me to introduce the first speaker. It's Mark Weinberg. He is a professor at McGill University in the Department of Medicine, Microbiology, and Immunology, and also the director of the McGill AIDS Center. He is a new investigator to the HIV cure field, and he will give us some information on the problem itself and on challenges and opportunities. Thanks, Mark.
Well, thank you, Matthias. So I think we all understand the problem in regard to curing HIV. First of all, we are dealing with a virus that integrates into host cells, and this creates a huge obstacle in regard to eradication. And we have to consider that we understand this virus pretty well, but it's not HCV. And I think we recognize from the outset when HCV took off in huge numbers and people and companies started to develop drugs against HCV, that it was really only going to be a matter of time until the eradication of HCV became a possibility. Now it seems to be a reality. And that was essentially because HCV does not integrate and HIV does, thereby establishing this huge problem. And over the years, we've learned a lot about the reservoir tissues into which HIV can reside. We've come to understand that the gut tissue is extremely important, along with other sanctuary sites, and in regard to continuing the persistence of HIV within individuals, including obviously those who are successfully treated and have virtually undetectable viral loads over long periods of time. There have been studies, as we all know, in which drugs have been withheld from patients in the context of drug trials, such as the SMART trial, and the outcome of that experience was rapid viral rebound and a lot of issues that represented real problems for the people from whom drug was withdrawn, including more rapid onset of comorbidities, death, in fact, in many cases. And a lot of this seemed to have been related to problems of exacerbated immune activation, which, of course, has come to represent one of the most important new topics in the HIV field. So with that, by way of background, I want to be deliberately controversial and, again, talk briefly about the compound about which I spoke during today's satellite symposium. And the question I pose is what if a drug that was developed to treat HIV infection could actually help to cure it? And the reality is that this slide, which is from the single study, shows how dolutegravir, together with abacavir and 3-TC, performed in superior fashion to the atripla combination, which really was a huge surprise, I think, to many people who never thought that it would be possible for a new drug combination to beat efavirenz. One of the other points that I think is worth mentioning is that the atripla arm of this study included the two nucleosides that make up Truvada, and there were a lot of people who had said, oh, Truvada is way, way better than Kyvexa, which is the combination of abacavir and 3-TC. And yet, you see here, the combination of abacavir and 3-TC together with dolutegravir did just fantastic. And one of the things that I mentioned today is that there has yet to be a single patient in any of the drug-naive studies involving individuals who are taking antiretroviral drugs for the first time of resistance to dolutegravir. So how is this possible? Is it possible that dolutegravir is a qualitatively different drug than anything that has come before? So our hypothesis is, in fact, that an accumulation of mutations associated with resistance to dolutegravir impedes viral replication, while at the same time, these mutations in combination act to increase overall levels of resistance. And I repeat, this is unprecedented because in regard to every single drug that had been developed until dolutegravir, including other integrase inhibitors, all of the protease inhibitors, and the nucleoside compounds, it was always a situation in which new mutations would accumulate and, yes, increase resistance, but at the same time, those mutations would act to restore viral replicative fitness. Here, there seems to be a dichotomy, therefore, between the increase in levels of resistance that is very real and the ability of the viruses to replicate. So that represents the basis for posing the question that I started out with. And our hypothesis is that this is what happens, and because of this diminished fitness, we just don't see resistance with dolutegravir when it's used in first-line therapy in the clinic. And the summary of all of this is on this slide, showing on the left the accumulation of a lot of mutations leading to viral failure, and with dolutegravir, the R263K mutation representing, perhaps together with supplementary mutations at position H51Y, an evolutionary dead end that prevents the virus from ever being able to recapture its growth ability. So, I've presented these findings a number of times at a number of meetings, and I've been roundly criticized. I have to tell you, roundly criticized, and I think David Margolis, in fact, was present in Miami when I presented some of these ideas. And one after the other, people like John Coffin and John Mellers and Dan Koritskis got up to the microphone and started to yell at me. And Mark, of course, they say, it's only a matter of time until there is a compensatory mutation for dolutegravir that is going to restore fitness. So all I can say in response to that is that we have tried desperately to try to show compensatory mutations in tissue culture studies that are now beyond 4 years in duration. We have not yet shown any such compensatory mutation. And we're now 6 months beyond that Miami CURE meeting, and there is still no report of a patient who has resistance to dolutegravir when that compound was used in first-line therapy. So I stick to my guns, and I say this is a qualitatively different drug. Now, let me just hypothesize with you about 2 offshoots of what might happen if dolutegravir indeed turns out to be resistant to the development of resistance in first-line therapy. So 1, if everybody in the world got dolutegravir and you can't get resistance against it and people take the drug, then they should have suppression of viral load, and that means, as we know, going back to the early studies by Tom Quinn, if you have suppressed viral load, you can't transmit HIV, and therefore the use of dolutegravir as first-line therapy on a broad-scale basis should help a great deal in regard to preventing onward HIV spread. That's not such a terrible thing. And 2, and this perhaps is more dreaming in color, but we have to reckon with the reservoirs. So somebody gets infected by HIV, they get infected presumably in almost all cases by a wild-type virus that, of course, winds up getting archived in reservoirs. So what if we actually did a series of treatment interruptions? You use dolutegravir, you obviously might succeed in converting the viruses that are actively replicating into dead-end forms, at least that's our hope. And then what if you took the drug out, and if you can't get resistance to it, you might be able to take it out and activate the cells and viruses in the reservoirs, and then go through a series of off-on treatments with dolutegravir and hopefully convert the viruses that are in the reservoirs also into these forms that are unable to carry out continuous replication. Now, you know, I don't want to tell you that I think we should do these things tomorrow in patients, but these are concepts that have the ability, I believe, to be tested in animal models, such as the SIV macaque model, and in humanized mice, and hopefully these things can and will get done. And as I say, no compensatory mutations yet. And thanks to everyone in our lab, and thanks to you for listening to me and not throwing rocks.
Okay, thanks very much, Mark. Yeah, you may have a seat. So there's now an opportunity for the panel to weigh in here and to give Mark a hard time. All right, Eric.
So Mark.
The mic's. Okay.
So Mark, why do you think mechanistically this drug is not generating resistance? Because, you know, usually we think of a good drug when you have resistance.
So the fact is, Eric, this drug does have a resistance mutation that is at position R263K. So the very existence of that mutation is proof that there is resistance that is possible, but it's very low level in resistance. It's very low level resistance. And what seems to happen here, though, is that the addition of the other mutations, as I said, very, very strongly weakens the ability of the virus to replicate. And you know, we've done modeling studies using a related virus. There's no crystal structure of the HIV integrase enzyme, but there is a crystal structure of a related virus called foamy-virus. So that integrase was crystallized by Peter Cherepanov. And we've used that structure to model where the R263K mutation resides. And it really seems to maybe be unique in that it's so strategically located that the addition of additional compensatory mutations that might restore fitness seems not to happen.
Marina?
So Mark, thanks. I guess the question is, and it was raised quite nicely today by David Margulies' presentation, about you're going to need a number of strategies, I think, when we're talking actual cure. So I suspect from what you're saying is that one arm of the strategy could be to target the virus, because everything else we've been hearing about essentially is partly targeting the immune system or getting the virus out of integration. How do you think that the drug in this case is actually going to combine with these other strategies? Because it seems it's maybe a complex.
Well, I'm the first to say that some of the strategies that David Margolis and others have pioneered, such as the use of HDAC inhibitors and so forth, is a strategy that could be combined with the dolutegravir approach, because we do need to activate those reservoirs. And everything hinges, of course, on dolutegravir maintaining, this aura of never having any resistance. But, we all know this. It's not a lie. Until now, there has not been a single patient who has received dolutegravir in first-line therapy who has developed resistance against it. That's without precedence in the HIV field.
So, Mark, all the patients that you're talking about, of course, are not receiving dolutegravir monotherapy. Yeah. So they're usually background nucleosides that are also exerting certain pressures. In this 4-year experiment in your lab, how is that being done? Is that dolutegravir monotherapy to select?
Dolutegravir alone as a drug that is used to apply pressure to the cells. And, look, I think personally that at some point someone is going to do a dolutegravir monotherapy study. I'm not suggesting it be done, but but Joe Gath did a Calitra monotherapy study, as we all recall, and we all know that the results that he obtained, in fact, were probably a lot better than anyone had expected. So personally, I would prefer to do a dolutegravir monotherapy study in SIV-infected macaques, and hopefully that is the kind of study that will be done first, because that's the kind of study that could really point the way and perhaps help an ethics committee to better judge on whether or not, the kinds of approaches that I've suggested could and should be done. I'm a firm believer in following strict ethics guidelines and relying on evidence to help us decide what should and should not be permitted to go forward.
So my feeling is we're going to have a very interesting discussion at the end of the individual statements here, and for now I hand it over to Marianne Harris.
Thank you. Thanks very much, and thanks, Mark, for that always controversial opening. It's my pleasure now to introduce Dr. Ari Bitten, who's an associate professor of pediatrics at the University of Toronto and a staff physician in the Division of Infectious Diseases in the Department of Pediatrics at the Hospital for Sick Kids. And I have to admit that as one of the organizers of the clinical track, we co-opted his abstract, which would have been presented in the oral session earlier today because we thought it fit in so well with our theme here. And so we're going to ask Ari to present some of his very interesting Canadian data on intensive antiretroviral therapy to a neonate. Ari.
So thank you very much for inviting me to present. I should say that I'm presenting this on behalf of a very large team that are listed there, centers across the country, and also involvement of the NIH. So my goal here is to cover briefly the Mississippi case, although I'm sure everyone has already heard about that case, and then focus mostly on some of our experience with early initiation of combination treatment in neonates, and finish off with some comments on what this has in relation to HIV care and cure research. So the Mississippi case, again, you've probably all heard of this. This was a baby born to a mom who was diagnosed with HIV infection at the time of labor, so did not receive any treatment. The baby had a PCR done early on and then was initiated on combination therapy at around 30 hours of life, achieved sustained virologic suppression by about 1 month of age, and that was maintained. This child was then lost to follow-up at around 1.5 years of age, and when they were re-engaged in care 5 months later, was found to still have an undetectable viral load. And the long and the short of it, after doing multiple investigations, including looking for replication-competent virus, they were unable to do so. So this was presented, I guess, in 2013 at CROI for the first time, and really was billed as potentially the first functional cure amongst a neonate. There were some controversies around that, which I'll leave, I guess, for people to ask. So this was a lot of interest to us, and the reason for that is that we had been using treatment doses of triple therapy in babies as HIV post-exposure prophylaxis for some time. So as a result of this case, we went back and looked at our experience. So at the 3 centers that I'm talking about, basically this is Sick Kids in Toronto, CHIO in Ottawa, and St. Justine in Montreal. We had 136 infants that got this such therapy. Most of them were either nevirapine or nilfinavir based, along with zidovudine and lamivudine. So in terms of vertical transmission, there were 12 cases of vertical transmission in this group, so a rate of transmission of 8.8%. Of those, 6 were likely in utero infections because their DNA PCR was positive within 48 hours of birth. And the other 6, the timing is less certain because their initial test was done after 48 hours. And of those 12, 4 achieved sustained virologic suppression, and I'll focus most of the rest of my talk on those 4, but I think it's worth stating right here that 8.8% is not a good number, and neither is not achieving sustained virologic suppression in a third, so that just reinforces the fact that our goal should be detection and appropriate treatment of the moms so that we don't have to worry about these cocktails in babies. So these are some of the baseline characteristics for the mothers and babies. There's a couple of points from this slide that I want to make. First of all, with respect to the CD4 counts in the moms, you can see that they had relatively advanced disease. The last 2 are the same numbers because these are twins. And then a couple of comments on the babies. They were all premature, some more, some less. And importantly, these 4 babies that I'm focusing on now all likely had an in utero infection because their PCR on day 1 or 2 of life was positive. So this is sort of showing the virologic decline or viral load decline in the first case. This is the only one that we had a viral load from day 1 of life. Our typical strategy is we do a DNA PCR, and if that is positive, we'll go on and do a virologic assay. But this one did have a viral load, and you can see it dropped from 1,890 to 276, 86, and then documented undetectable viral load around day 180. So just to make a comment, so this case is a little bit different than the Mississippi case. If you remember, the suppression occurred a lot faster in that case, around day 30. So just that's something to keep in mind. So this child's now 7.5 and has maintained an undetectable viral load since, remains on the same combination and is well. The second one, I won't spend too much time. It's a child of the same age as a positive DNA PCR on the day 1 of life, and then 2 low-level detectable viral loads and suppression around 3 months of life. And then the twins, a similar story, DNA PCR at the time of birth, and then 2 detectable viral loads before suppressing, 1 between a little after 2 months and 1 at around 3 months. So again, the 4 cases are slightly different than the Mississippi case in that sense. The other difference being, of course, that they're still on therapy. So we went on and investigated these kids further. I'm not going to go into too much detail here, just to say that we did HIV serology. We did HIV-specific cell-mediated immune responses in Mary Ostrowski's lab, Richard Harrigan in the HLA and CCR5, and then a variety of virologic assays, some of which were done at our national lab with Paul Sandstrom, and some of which were done in Tai Wook Chun's lab at the NIH. So that included ultrasensitive viral load, proviral DNA, cellular RNA, and replication-competent virus assays. So this is the immune responses, and just to say this in brief, all 4 had negative serology, and none of them had detectable cell-mediated immune responses to HIV. I should point out, though, that this is not that surprising for babies. Even if you start treatment in babies at 3 to 6 months, it's very often that they lose their antibody and lose their HIV-specific immune responses. So this in itself is not very surprising. So this is the viral reservoir assessment. So ultrasensitive viral load was negative in all 4. Proviral DNA was also negative in all 4. RNA, you can see, was a low-level positive in all 4, and this was a finding that we still have difficulty explaining, especially considering the fact that in the assay just below that, the HIV RNA and stimulated CD4 cells. So this is CD4 cells that were stimulated mitogenically, and then RNA sought for replication-competent virus, and this was negative in all of the cases. You can see the number of cells that were used in millions. So this kind of suggests that maybe that RNA that we detected was maybe replication incompetent virus, but really we're not certain. And then just hot off the press, a little bit of bad news. So we sent off co-culture on the 2 older kids, the 7.5-year-olds. We took about 40 cc's of blood, which was kind of pushing it in terms of how much we can take. And in one of them, there was 1 infectious unit detected per 10 million cells. So a little bit of bad news there in that one. With respect to genetics, all 4 were wild type for Delta 32, and genetics, what was interesting here is the 3 that had protective findings, so HLA B58 and the mutations in HLA-B that are associated with slower progression, were the 3 that did not have replication. So the one that had replication-competent virus detected did not have these protective alleles, the others did. So it's obviously only 4 patients, hard to know what that means, but it is interesting. And then this was presented earlier today by Lindy Sampson. This is kind of a word of caution. So this was our 5th case. This was also a child that was started on treatment right away, had a positive PCR, several detectable viral loads. A little bit different in a couple of respects. One had 2 virologic blips early on, 1 to 83 and to 40, and then achieved sustained virologic suppression. The second difference was that this child was found to harbor nevirapine resistance, and so treatment was switched at around 3 weeks. But like the others, had negative ultrasensitive viral load, negative proviral, and no detectable replication-competent virus. Because of issues around adherence, there was a clinical decision to stop treatment in that child at around 3 years of age, and a virologic rebound occurred 2 weeks later. So just to summarize all this, I think, again, our primary goal should be to diagnose and treat the moms appropriately, and then we don't have to worry about giving the babies triple therapy. But having said that, mishaps do happen, and we continue to see those babies. We just had one a couple of weeks ago at Sick Kids, which is unfortunately infected. But if we do see these, I think it is justified to start combination treatment within the first 72 hours and preferably on the day of life, because I think there is definitely a chance that we could at the very least reduce the HIV reservoir substantially, which could impact their long-term outcome. And then lastly, I think in these kids and in general with pediatric cure research, we're probably going to have to stop treatment to know if there's functional cure or not. I don't think assaying the blood or even other tissues is going to really tell us the true answer. So with that, a couple of implications for pediatric HIV cure research. I think babies are an ideal, or in some ways an ideal group, because we know the timing of infection. We're starting them on treatment right at the time of infection or soon afterwards. On the other hand, there are some practical and ethical issues. Getting enough blood is difficult in babies, and the acceptability of doing invasive procedures is problematic. And lastly, there's also some ethical questions around whether or not it is appropriate to do a structured treatment interruption. So with that, I'll thank the children and their parents that have been so good at agreeing to these investigations, and I'll finish there.
Thank you, Ari. Really interesting data. I wonder if the panelists have any comments they'd like to make. Dr. Margolis, perhaps?
I have a question.
Of course.
So, in a very friendly way, let me ask. So I think you said in passing that these sorts of research assays would not be done in children, could not be done in children broadly. And you showed us data from one child who replication-competent virus was actually recovered. Mm-hmm. I assume you would not submit that child to a treatment interruption study. And if you would not, then shouldn't every child have such an assay before going into a treatment interruption study?
Well, for sure I would do the assays. I think what my point was more that with the number of cells that we get to assay is so small that really getting a negative result needs to be taken cautiously. it's just as, it's possible that the other kids have 1 in 20 million cells that are replication competent. We're just not picking it up because we're not getting enough cells. I think that's.
I just wanted to sort of
yeah.
be out there with that because I've heard people say the opposite. Say you don't know anything until you stop treatment. And this culture, maybe it's not really replication competent virus, so we would stop treatment.
Well, I'd go for, I mean, I have been, what I would like to do, in fact, is I think we should at the very least do gut biopsies on them. I think going beyond that is going to be difficult. There are people that disagree with me on that. My personal feeling is we should get gut biopsies
Dr.
before
Weinberg?
we were to stop.
First of all, I think the work is great, and congratulate the team for these very nice findings. And in some ways, it seems to me that you have cases for whom the evidence of real HIV infection in these babies is perhaps even stronger than in the case of the Mississippi baby. But I want to ask about the fact that historically, when HIV-infected women gave birth to their offspring, it only happened about 25% of the time that the babies were born with HIV infection. The other 75% of babies seem to be okay, and then very sadly they may have become infected through breast milk, but at least at time of birth, they don't seem to have had HIV. So my question is, why only 25% or so of babies with HIV infection? Do you think that maybe newborns have some way of dealing with HIV that enables clearance to take place in a more effective manner than might otherwise take place? Because presumably all these babies were somehow exposed, and yet the rates of infection seem to be relatively low.
Well, okay, I don't think I have the full answer to that question, but I would kind of turn it around and actually say 25 is pretty high. If you take sexual transmission, the risk is much, much lower. So I think I would turn that around. And it's true of all infections, really, all congenital infections. There's only a certain proportion that get transmitted. There's so many factors involved, be it the placental function, how long is the birthing process, how much blood is involved, and so forth. But truly, there's probably factors that we don't understand as well.
Anyone on this side before we move on?
I guess the question I have is that I think this is, gradually you're trying to do more than the N of 1, so we're trying to document this in a way. But what will this inform us about cure in adults, particularly? Because I think it's a very unique situation, the pediatric situation, and it's very hard for us to catch individuals that close to the time of their acute infection. Certainly we can do it, but not on a wide scale. And how much will this be informative for cure in adults?
Yeah, so I think, well, hopefully there won't be that many babies that need this, but the reality is probably there are. I think you're right. I think the big advantage is that we know approximately when their time of infection is. I think there are some immunologic differences between babies and adults which might complicate this, and I think part of the research that we will hopefully start is to look into some of those differences as well, because there are differences in terms of immunologic maturity.
Thanks. Hopefully in the discussion period, we'll have a little bit more time to address the issue. You look like you got something burning.
No, I can ask my question later.
You sure?
Yeah.
I don't want to cut you off. Our time is short, though. I'd like to next introduce Dr. Adrien Levy. It's a real pleasure and honor to have him here all the way from Dalhousie University. And I knew Adrien in his previous life in Vancouver when he worked for UBC and the BC Centre for Excellence. And so we've asked him to come today to give us a little bit of a reality check in terms of the economic issues around a cure and whether that's realistically possible. So, Adrien.
Thank you. Thanks, Marianne. Madam, Mr. Speaker, great pleasure to be here in my neck of the woods now. It's a great pleasure to see some of my former colleagues from UBC and be with them. What are my disclosures? One, I'm not an HIV researcher, or certainly not exclusively an HIV researcher, and I haven't done any work on HIV since I left Vancouver 5 years ago. Second disclosure is that I have no team. This is me. And my third disclosure is I have no money. This is unfunded. I came up with this very catchy title, The Economics of Eradication. For the first time, I thought, yes, I've got a really catchy title for my presentation. And I Googled it, and I'm only the 501st person to come up with this title. What are we doing here? The question, I guess, indirectly Marianne asked me is, can we eradicate HIV/AIDS? And what I'm taking as a given is that we find some sort of vaccine or cure, some sort of therapy that works to actually eliminate the virus. And so as I was sitting here listening to you folks, I was thinking, wouldn't it be wonderful if someone from CAHR won the Nobel Prize one day for having come up with a cure for HIV or a vaccine? It'd be a very exciting day for all of us. Given your success, let's just give a bit of a thought experiment. So what I did is I started looking at other areas where we've come up with some sort of vaccine and looked at what happened in those cases. And the biggest success, the only human success that I could find, I think almost the only human success, the only big human success was smallpox, where in the late 1970s, 78 or 79, after 18 or 19 years of very hard work, we managed to successfully eliminate that as an infectious disease. Following that model, we started trying to eliminate polio, and worked very hard, i.e. spent a lot of money trying to eradicate polio. So far, because it's more complicated than smallpox, we are yet to be successful, although many organizations have claimed that we would be successful in a short period of time. We have yet to be successful with polio. And what I'm going to present to you is just a few thoughts from a socioeconomic perspective, and one of the messages is that the socioeconomic perspective has to be linked to the epidemiology. This is a graph from a very interesting article out of that well-renowned scientific magazine, Wired. They talked about, I came across this, there's a very interesting article called The Surge, where they talk about some of the hurdles of trying to eliminate polio, and they talk about being in eastern Afghanistan, where they've just had that terrible earthquake, trying to vaccinate children there, and some of the political hurdles they face. And they make it very clear, I don't know what, do we have any pointer material? I'm sorry.
It's in the middle, maybe?
Yeah, I don't think it works. I'll just draw your eye. Do it. So the projected annual cost is up on the y-axis, and then here are calendar years that are along the bottom, and you can see that the big greenish bluish bar, that's how much control costs. So $1.5 billion per year to control. And if we were able to eradicate, if we were able to add, say, rough number, $750 million for several years, all of a sudden we have this huge drop-off. If we're able to put over a 5-year period, we were able to eradicate polio, you get this huge saving over time. So the economic proposition is just a no-brainer, or at least from one point of it, or is it, is better the point. Well, here's a second graph that they show in that same article, and again, on the x-axis, the abscissa, you've got years running now from 1988 through 2012, and the total number of reported cases. So going down from close to 400,000 cases being reported in 1990, way down to into the small number of thousands. But on the right-hand axis, you see the cost per case. So actually now it's becoming so rare that finding every case is up around $2.5 million for the annual cost. So the cost is actually, the incremental cost for trying to eliminate polio is now going up over time. So it's a very different argument now that in terms of trying to eliminate polio for the amount of money, funding that would have to go into it. And this is economics, health economics 101, where you say that if you invest something, if the cumulative cost is on the left axis, with time over time and the health benefits are in the dotted line, you can see that perhaps in the first 10 years or 15 years after investment, you're not going to see some huge health benefits, and then the health benefits would accumulate over time. This is certainly the case that we would be in if we found the magical cure for HIV. Well, when you talk about making investments today for benefits in the future, there's an important thing that you need to take into account, and that's called discounting. Because a dollar tomorrow is not worth the same as a dollar today. We value a dollar today more than a value tomorrow, and so we discount it. That's why we have interest in banks. And the amount that we discount, and this is a conceptual issue. I mean, technically, I just want to show you an example of it, but it's a conceptual issue as to how much we want to discount. So this is exactly the same issue in terms of moderating climate change, by the way. So say we invested $1 trillion today, and the top blue line shows what happens if we discount at 1.5%, so quite a low rate of discount. After 50 years, that $1 trillion today would be worth $497 billion and $247 billion after 100 years. So it's just an exponential decay here, very simple. And really, that if we discount at 1.5%, we still, that's quite valuable. On the other hand, if we value dollars today much more than we will in future, and we discount at 6%, after 50 years, $1 trillion in today's terms is $50 billion, and it's down to $2.5 billion in 100 years. So you're really not getting a good return on investment if you think about what you discount. And the rate that you actually discount is a conceptual issue. Technically very easy to calculate, but what rate you choose is now an ethical issue. As soon as you talk about allocation of resources, you're into ethics. So here are just some of the issues, and I've just got 3 slides, a bit of a shopping list of political-economic issues that I would see, assuming trying to get a cure out there. First is the discounting that I just talked about. Then we have to talk about technical efficiency or incremental cost effectiveness. And so now when we're thinking about incremental cost effectiveness, it has to be a relative incremental to our current therapy, i.e. heart. So we need to think about actually the technical efficiency of our curative therapy. And then there's allocative efficiency. Do we want to spend that money on HIV versus other infectious diseases versus treating other diseases, or perhaps to improve the health of the world, we'd be better off investing in roads in Africa, that money might be spent in a completely different area of society. So these are some of the issues that need to be addressed. There are huge political issues in the difficult world that we live in. Who leads the process? Is it international agencies? And what is the area of cooperation between international agencies and local health authorities? In terms of the financial issues, it sounds like there'd be, if big pharma, research-based pharma is involved, they're going to want to see that, especially if they have a curative therapy, which will cure people so they no longer are patients, they're going to want to see a high return on investment. And it sounds like you were discussing HCV yesterday, where Sovaldi is $80,000 for 12-week therapy. Even payers in the United States are balking at that. And it's going to be a huge issue. Imagine in the third world what's going to happen where patients with HCV are demanding it. The budget impact, even if it is deemed cost effective, if we think the incremental cost effectiveness ratio is good, it may just overwhelm the budget. We may not have any health budget if we only treat HIV. And then who pays? Which countries decide to pay? Is it developed countries that are going to pay for this in developing countries? Huge issues around that, and it leads to the possibility of free riding, where a country understands that every country around it, say a country in the middle of Africa, chooses not to invest in this because they know all their neighbors are investing in it, then they're free riding through a herd immunity. They're going to benefit from what their neighbors are doing. There's huge social issues. What is the population that's going to require immunization of this perfect cure? Do we target high-risk patients? Then there's these issues around diagnostic testing and the long period of diagnostic testing versus general population, the risk of stigmatizing people if we think they're at high risk, if we want to do this. Some of the practical issues from an epidemiologic point of view, well, this is why HIV is more complicated than smallpox. There's at least 3 sources of transmission that we know about. You folks know, I know of 3, you folks know probably more. There's a long empirical lag period, so people get infected and before they show symptoms, there's a long period. There's no visual detectable signs, unlike smallpox. And of course, what will be the killer in Africa is that there are reservoirs of new infections, so we will never be able to eradicate it for that simple reason. A few of the features of immunization, if we have a magic cure, say some of the things that you folks are talking about, we have to talk about sterilizing versus a functional cure and the differences between those. I think what I was hearing about were functional cures today and no sterilizing cure. The take and the degree of the immunization, whether it's an all or nothing or whether there's different degrees of effectiveness. The duration of protective, say if we're looking at some of the vaccine trials, what is the duration? They're going to be short trials that are showing benefits. Will we need booster doses? All the issues around potential supply chain management. So in conclusion, can we eradicate HIV/AIDS? No. There are too many huge challenges, socioeconomic challenges to eradicate this disease, unless there's huge and unlikely cultural and societal changes all across the world, not only in this country. But elimination will be possible, I believe, with good work of agencies like CAHR and others. Everyone's working, I think, in developed countries. In our country, we will be able to eliminate it or largely eliminate it. It's going to cost us a lot, but I think we would be able to do it. And as we're seeing, we're definitely going down the right road because control, it certainly will allow us to improve control of the disease. So thank you very much.
Thanks, Adrian. For someone who hasn't worked in the HIV field for 5 years, you did a great job catching up, and it's always good to get a perspective from someone outside. So welcome the panelists. I cut Dr. Cohen off last time, so if anybody has any comments or questions on Adrian's presentation. Yep.
I've got a question. Is what I'm saying controversial, or I'm not saying heads nod or shake?
I just say it's wrong.
Okay.
Would you like to elaborate?
Well, I think you
My mother dressed
staked a pretty certain position on the future, which is risky. I think that a number of years ago, it was widely held that antiretroviral therapy would never be employed in Africa, and someone to my left had a very big impact, and it's now widely employed in Africa. So I think that the future is uncertain. And I think we need to decide what the important goals are and how we can move towards them. Not just one goal, all the goals. It might be that it's more cost effective to save the world from global warming than it is to eliminate HIV, but I just can't tell. So I think we should try to do what we think is good.
Adrian, do you have a response?
Please don't misunderstand me. I'm not saying that the effort is not worthwhile. I think we need to be very cautious when we commit very large sums of money to this, because they're conceptual issues and they're technical issues which make this very, very challenging. I'm not suggesting that the effort, we absolutely should look at this very closely. We should evaluate it within the context of other interventions that we have. And decide what we think is best. And it doesn't take one whit away from the research that's being done in this. I think we have to be realistic about what the expectation is.
Dr. Weinberg.
So if I could just add one thing to what David said. First of all, I think that all of us who are working on our own ideas about how best to achieve HIV eradication, and our ideas are in fact diverse, agree that we all believe that this is something that can be accomplished, because I think if we really didn't believe that, we wouldn't be in this. So we do believe that we, as a field, will come up with a way to eradicate HIV at some point over the next 25 years, let's say. Second, I think to make an economic argument, and certainly leading economists have said this, we have to do it because there's no choice. The current availability of drugs to fight HIV on a worldwide basis is just so expensive that what we're doing now is not sustainable. This has been pointed out by many people. And you know, if we don't find a way of dealing with HIV by really trying to cure it or prevent its transmission, then people in developing country settings are in fact going to backslide, because the Global Fund and the rich countries of the world are simply not going to be able to keep up with the need for new drugs. And of course, the problem of drug resistance, such as it is, will make, in the future, treatment perhaps more difficult than it has been until now, because there's no question that the rollout programs of antiretrovirals in developing country settings have brought with them a lot more transmitted HIV drug resistance.
Thank you, Mark. Any comments from this side of the panel? I'm really not ignoring you, I promise. Before we open it to the audience, Marina?
Oh, I was going to say open it to the audience because I'm sure there's lots of questions. I have other comments, but I think we don't have that much more time. So.
Yeah, we'd be happy to hear comments, questions from the audience. I believe there's microphones roaming around. Yes, in the back.
Mark Tyndall here.
Hi, Mark.
Hi, Marina. Just one quick question about one of the things that I think is holding us back is this inability to have good animal models and to test this. And twice it came up that if only we could do this ethically, it would really help. And the one example was, Mark said, a dolutegravir monotherapy, and then it came up to Ari that, if only we could stop this structured interruption. And I think that's being so overly cautious, and it's, to me, much more unethical not to do this with all that's at stake. So we're focusing so much on, the individual who, the two examples we used, there's absolutely a no risk versus what we can learn from this. So I think we really need to think seriously about what ethics we're trying to protect here.
Next year, maybe we should invite an ethicist to the panel. Any comments or reflections on Mark's? Yes.
Well, I mean, I can comment on the children.
Yes.
I mean, I would like at some point to stop, but I think it's a question of when do you have enough evidence that you feel that that is a reasonable thing to do. And so for me, I think having repeated blood tests and perhaps gut biopsies, if the feeling is that the level of HIV is so low that even if there's no eradication, there's a good chance that they're functionally cured. I think then, with appropriate precautions, twice weekly viral load, for example, ultrasensitive viral load, and very close follow-up, and of course, after explaining all of this to the child and the parents in this case, because they're quite young, then it would be reasonable to do.
Marina.
Yeah, I think I'd just add that with respect to, for example, dolutegravir monotherapy studies, I don't think it's actually required to do an proof of concept in an animal model first, possibly, as we have many precedents for monotherapy trials in HIV, provided that there's proper informed consent, because what you're risking is potentially resistance to one class of medications, and it may be, if it's so potentially beneficial for other reasons, that could be in a pilot type of situation, something reasonable for someone to consent to participate in and could give us valuable information. But with children, one of the questions you worry about, especially with the case that was presented in the oral session today, is why, with that virologic rebound, those kids who may have had very low reservoirs because of their initial very early treatment suddenly now have reservoirs like anybody else who has a chronic infection, and they've been changed. It's a dramatic change for their individual health that could potentially be detrimental going forward.
Good. Anyone else in the audience like to contribute?
I can only invite you to a conference in Geneva next week for 3 days where that's all they will talk about, which is the ethics of cure research. So I think a lot of people are spending a lot of time talking about it.
Excellent. Thank you.
If I could.
Yes, Mark.
Yeah, so I just want to, again, say that I fully support the notion of doing animal studies first to provide evidence, that goes as far as we can in regard to what might eventually be carried out in the clinic. And in regard to the hypothesis that I enunciated, I want to make clear this is a hypothesis that my lab colleagues and I have brought forward, but it is not supported by the company that manufactures the drug. In fact, they are, a little bit wanting to remain behind the scenes and watch what happens because most drug companies are very conservative in their approach and don't want to get directly involved in regard to doing things that would perhaps go beyond what is currently accepted in the field as representing a truly ethical approach at treatment. So they would certainly say that they would be fully opposed to any attempt to use monotherapy with dolutegravir at this point in time.
Thanks for that clarification. Yes, I haven't given you a chance to speak yet, so I feel you should have the floor.
So I had a question for Ari. It's maybe a naive question, but in the case of these pediatric cases, given that these children have a immature immune system and develop a minimal immunity against HIV, how do you think these reservoirs are eliminated?
Well, I don't know that they're eliminated. I think probably what's happening is you're starting them on treatment so early that maybe you're limiting the size. I think there's data from, I think, Thailand in adults that we heard about earlier this week. If you pick up the infection very early, when their viral load is still sort of in the early phases of climbing, that you limit the size of the reservoir. So I think in infants it just happens that we know approximately when they're infected, and so we're achieving that same thing, perhaps. I mean, this is theoretical. I don't know that it's true.
Mark.
So I would like to ask David Margolis a question, because he really is the first person I know of who has tried to do imaginative things like stimulate patients with HDAC inhibitors and see what happens. And those were very courageous studies. But where do you see the field going in regard to development of new drugs that might be able to help us to purge the reservoirs? But obviously what we'll need to do is make sure that the drugs we use toward this end are very safe in their own right. We don't want to use carcinogenic drugs, and so the whole field is a bit fraught with some degree of uncertainty.
It's fraught with, I think, just the same tension that you're hearing from up here and back there. Don't do anything bad, be careful, but hurry up and get us some answers right away. So the Verinistat SAHA study was at the FDA for almost 3 years before we got approval. Back and forth, more data, etc. That's not to say that we know that those patients, that we're not harming those patients now. All of those patients are in a registry to be followed for the rest of their life to see if they get cancer at some higher rate or whatever. But there's a lot of evidence that there's only marginal evidence that that drug is actually a mutagen. Again, it's very difficult to sort of answer this question in one way, because every approach is different and has very specific costs and benefits. Children are much different than adults in this regard, in certain ways. I think the issue of consent in children is much, much more difficult than in adults. I'm not saying anything that's especially intelligent. These are widely known. I just think that it's really important for the field to realize that we're in this for the long haul, that it's not a one approach fits all, that cure is not the only thing that needs to be done in HIV medicine, and HIV medicine is not the only thing that needs to be done for the developing world, etc. We just sort of need to not sort of go for the headlines and try to find progress.
Fair enough. Any closing comments from the panel before we wrap up? That may be a good place to end, I suspect.
Thank you, Mark and Adrian, especially for injecting a little controversy into the session this afternoon. Thank you, Ari, for presenting your interesting data. Thanks you to the rest of the panelists and to my co-chairs, Marianne and Matthias. And thank you to the audience for coming out late in the afternoon, and now send you away to return by 7 o'clock to be separated into teams for the Rally in the Alley Gala. Thank you.